Okay. Thank you, Dr. Son and Cindy, for the kind introduction. And also thank you, Dr. Yu and BioMTA, for giving me this platform to speak and share my journey in MTA obturation. I understand that, bearing in mind that there may be some language barrier, so therefore I'll be mindful to speak a little slower. And also this lecture, as mentioned, will be uploaded. So if any of you want to revisit the contents, you can watch this on YouTube. So, yeah, as mentioned,
Okay,
I was from Malaysia, but moved to Singapore to further my studies in endodontics. I have 3 kids now, 1 boy, 1 girl, and my most recent baby will be the Esther. So let's begin with the main goals of root canal treatment. Firstly, is actually to prevent and to treat the apical periodontitis by removing irritants from the root canal system. Secondly, we want to prevent future reinfection of the root canals by obturating and sealing them completely. The concept of obturation has evolved with time. In 1967, Schilder introduced the concept of 3-dimensional obturation of the root canal system to prevent ingress of the microorganisms and tissue fluid into root canal space. Then in 1998, Sundquist and Figdor introduced entombment of the intracanal bacteria in dentinal tubules. This is to deny them access to periradicular tissues. And then in 2014, Dr. Yu introduced the concept of bacterial fossilization through intratubular biomineralization. A quick recap of what constitutes an ideal root canal filling according to Grossman's criteria in 1946, which includes easy placement in the canal, able to fill the main and the lateral canals, no shrinkage, unaffected by moisture. It should be antimicrobial, radio-opaque, do not discolor, biocompatible, and retrievable. Based on this criteria, gutta-percha with conventional sealers does present with some limitations in fulfilling these requirements. Instead, the bioceramic counterparts seem to have better overall performance, but certain drawbacks still exist in terms of discoloration and retrievability, depending on the brand as well. So for discoloration, some brands contain bismuth oxide, such as ProRoot, OrthoMTA Generation 1, Endosem, Angelus, and among many others. However, newer generations of MTA, such as RetroMTA, are now using zirconium oxide, which does not discolor. In retreatment, MTA, both MTA and BC sealers are not easily removed, but some manufacturers have developed some specially formulated solutions for this purpose. In terms of fulfilling concepts of goals of obturations, with conventional sealers, they do present with many limitations due to problems with shrinkage, voids, leakage, and they do not have bioactivity. In contrast, these are more achievable with the use of bioceramics as they expand slightly and they form mineralized crystals that can seal more effectively. Next, I want to share the common technical limitations that I face using gutta-percha with sealer technique. Firstly is the ability to seal to apex optimally. With gutta-percha, we are to end 0.5 to 1 millimeter short of the radiographic apex or at the apical constriction per se. This is to reduce the risk of extrusion and potential foreign body reaction. To do so, we need to really measure precisely and mold the tip of the master cone so that there is tuck back, signifying adequate seal. However, with time, we do know that gutta-percha suffers from shrinkage, and this can compromise the apical seal. In infected cases, obturating to apex would be most ideal, and this is achievable with MTA. And as supported by Terauchi et al. 2023, MTA obturated flush with or field beyond apex yielded better treatment outcomes. The next limitation was obturating an open apex. I find that it is hard to control the length, as the bulk of the gutta-percha will likely extrude and touch the apical tissues, or we want to tend to feel short instead to reduce this risk. Hence, it's hard to find a sweet spot for gutta-percha, but this is not a problem with MTA, as this cement has excellent biocompatibility and bioactivity that is conducive to healing. The third limitation that I want to highlight was the management of resorptions and perforations that are inaccessible for MTA repair before we obturate with gutta-percha and sealer. Just like this case, there was apical transportation and perforation. So with MTA, I was able to root fill and repair the perforation concurrently and effectively, regardless of the location of the perforation. As you can appreciate from the 8-month post-op review, there was complete healing with re-establishment of PDL and lamina dura. So briefly about the origin of MTA and how it evolves over the years. Professor Toribinejad developed the MTA about 30 years ago from construction Portland cement. It was initially meant for perforation repair, and they subsequently explored it in apical surgeries and vital pulp therapies. Then, about 15 years ago, Dr. Yu developed OrthoMTA from medical grade pure reagents with the intention for root canal obturation. And in 2018, OrthoMTA 1 was HSA approved and available in Singapore, and that was the year that I started using. So in the composition of MTA, the key active components that are of interest to us are the calcium silicates, as they form calcium hydroxide and calcium silicate hydrate gel that are responsible for the anti-inflammatory, antibacterial, and bioactivities. In ProRoot, they are obtained from purified Portland cement, but inherently, it also contains other trace elements which are toxic. But in OrthoMTA, those toxic elements are absent, which makes it a comparably better material to employ. I have put together a summary of many advantages of MTA in obturation. Biologically, MTA has excellent biocompatibility, is antimicrobial, anti-inflammatory, has bioactivity that can potentially encourage rapid healing, as well as the formation of minerals and crystals that promote adhesion to root dentin, hence the hermetic seal. Physically, MTA is dimensionally stable and is insoluble in tissue fluids when they are set. With newer MTAs, discoloration is minimized or absent. It does not shrink, but expands instead. It's worth mentioning that OrthoMTA has a minimal setting expansion less than 0.1%, which is in accordance with the ISO standards, as compared to 0.28% in ProRoot MTA. There also has been evidence to suggest that MTA can increase resistance against fracture. Technically, from a technical perspective, MTA is not moisture sensitive, which works to our advantage in a wet root canal environment. It has sufficient working time to allow proper compaction. OrthoMTA per se is easy to manipulate and handle because they have designated carrier and compactor. In addition, the use of MTA also simplifies apical surgeries and perforation repairs. So let me share with you the first case that led me to use MTA in obturation. I had a patient with persistent palatal sinus tract of 2-6. Despite repeated root canal redebridement, calcium hydroxide dressing, and increasing the master apical file sizes. So on the third visit, we decided on apical surgery as the patient refused extraction. Hence, the palatal canal was obturated with biodentine. I did not have OrthoMTA then. So the choice of biodentine was made mainly because it sets in 12 minutes with low risk of washouts from the large palatal sinus tract, and I can perform simple root resection with no need for retropreparation and retrofilling. However, biodentine lacked the radial opacity required in the two-dimensional radiographs, and I was not able to check if obturation was done adequately. Also, the working time was relatively short, and I had to race against time to compact the canal properly before it sets. There was also no suitable carrier, and the cement mix was quite sticky, which made the handling rather challenging. After the obturation, patient did not return for apical surgery as planned. So when contacted, patient said that the infection on the palate is gone. So I reviewed her at 3 months, and clinically, the tooth was asymptomatic, and the previous sinus tract has healed, leaving behind a small scar. Radiographically, the periapical lesion had decreased in size, indicating of healing. Hence, the epicoectomy was not necessary, and she was advised to crown the tooth as soon as possible. So I began exploring the use of biodentine in other cases, such as in strip perforation, because of overzealous removal of gutta-percha during retreatment, and also in persistent post-treatment infection. And both of these cases showed great healing and stability. So I began looking into OrthoMTA. The biofilling kit was a great starter pack with complete sets of tools necessary for MTA obturation, such as the carrier, compactor, and the plugger. And they also have engine-driven MTA compactor to obturate the canals. But being an endodontist, I appreciate better the tactile control of K-files to compact the MTA to length. Hence, I came up with my own manual compaction technique with simple armamentarium. But it's just a matter of preference, personal preference. So since then, I have used OrthoMTA in all my root canal, and regardless of complexities, and I'm truly enjoying all my work, seeing great results despite the initial challenges to try to compact them properly. And I have not stopped since. Then in 2023, I had the opportunity to collaborate with National University Centre for Oral Health of Singapore to run a randomized controlled trial. This is to compare treatment outcome between the OrthoMTA and gutta-percha with BC-Sealer, and the trial is still ongoing. So the residents were calibrated using the manual compaction technique. So with this technique, you can start with K15 or 20, depending on the size of your canal preparation. So, and the file should be able to move quite freely without binding the walls. So in this case, the mesial canals were prepared to 2504 due to its very slender root. So I started with K15 for the apical 2 mm, followed by K20 to achieve the apical 5 mm of MTA plug. The rest of the canals were gradually compacted with increasing K-files followed by endopluggers, supplemented with paper points in between to remove excess water from the MTA mix. Another technique which you can employ is by using the engine-driven MTA compactor. So a short video clip. The recommended speed is 60 to 100 RPM with 0.2 torque. So the MTA is carried into the orifice using the carrier, followed by initial plugging with a condenser. Then lightly push to length with the compactor and start the engine. As the apical plug began forming, from the compactor, you can feel a sense of stickiness from the compaction itself. So on my end, I still supplemented it with a K20 to make sure that I truly bring the MTA to length. And you can continue with the sequence until obturation is complete. So in this case, I completed it in a single visit. And straight away, post-paste prep and complete it with the composite fiber post. So next, I want to share some of my observations and clinical experience in using OrthoMTA in obturation. So in the past 5 years of using OrthoMTA, I noticed that there was a faster healing rate. This is especially very helpful when endoprognosis is likened to be 50-50, and we are unsure whether to proceed with crowns where costs are a concern. So this case had many odds against it with 10mm probing depth, grade 2 mobility, and very extensive endoperio involvement. So with adequate treatment and MTA obturation, significant radiographic healing was observed at 3 months, and the tooth mobility returned to normal. She was sent back to her dentist for crown, and at 6 months, further bony infills can be seen. Also, with faster healing rate, it can facilitate surgical treatment planning when multiple teeth are involved. So as for this case, there were large periapical lesions of 1-2, 1-1, and 2-1, with suspicion of radicular cyst of 1-1. So after obturation with MTA, we decided to monitor for healing first. During the 3 months review, radiographic healing was observed in 1-2 and 2-1, but the 1-1 was non-healing. Hence, we planned for surgery for 1-1 and leaving 1-2 and 2-1 alone. So fast forward 1.5 years later, you can see that the healing is complete. Also, with expedited healing, we can also treatment plan better and have higher level of confidence in the trajectory of the direction of our treatment plan, especially when it involves the placement of implants next to an infected tooth. In this case, 3-6 had to be extracted due to vertical root fracture, which leaves us to wonder if 3-7 will respond to treatment because the previous RCT seemed adequately done. Hence, the question looms whether I can do better than this. But we went ahead with the retreatment and MTA obturation. At 6 months post-op, radiographic healing was evident, and we gave green light to go ahead with the 3-6 implant. And at 1 year review, healing is complete and 3-6 implant is secured. With MTA obturation, apical surgeries became relatively simpler, neater, and also faster. In most of the cases, it was just a simple root resection with no need for retro preparation and retrofills with MTA. So in this case, 4-year post-op, healing is complete and stable. Similarly, for this case of tooth 4-1 epiquectomy, it only required a simple root resection, and we can appreciate that the OrthoMTA was well compacted in the oblong-shaped canal, and the material was hard and set. Therefore, there was no need to refresh the MTA root end filling. And at 6 months after the apical surgery, the healing is complete and 3-1 implant is secured. In cases of resorptions and perforations, repair was easy and convenient with MTA, as the cement was able to flow into those sites due to the hydraulic pressure generated during the compaction. This case had a transported canal this 2-6 has a transported canal and perforation in a distal buccal root, which was successfully treated and sealed with the OrthoMTA, and the repair remained stable with the overall healing of both molars, 2-6 and 2-7, favorable during the 3-year post-op review, with re-established outline of the maxillary sinus floor, reduction in the periapical lesion, especially the mesiobuccal root. In the next case of external cervical root resorption, the root canal was obturated with OrthoMTA, but the repair was done with biodentine, mainly because of aesthetic concern. As mentioned, OrthoMTA 1 contains bismuth oxide, and we do not have the newer generation 3. So alternative to biodentine, we can actually use retromTA, which is the 2nd generation product of the BioMTA. So it was developed for vital pulp therapy, perforation repairs, and apical surgeries. This material has an initial set of 3 minutes with no problem with washouts and is non-staining. Similarly, with this case of palatal root resorption caused by impacted 2-8, it's almost hassle-free to use MTA to seal the resorbed root, as the cement can flow into the irregularities without causing much negative reaction from the surrounding tissues. All of these cases are only possible because patients insisted on saving the tooth and refused extraction. So truly, saving this molar was made possible also because of MTA, and I do not think it is achievable with gutta-percha and sealers. In situations where extractions are not an option, or in patients again unwilling to lose their teeth, often MTA is considered as a last resort in controlling root canal infection. Both of these cases, retreatments were successful, and it bought the patient some time, at least until they were ready for extraction. The same goes for this cracked tooth. 4-6 had a probing depth of 5 mm, which corresponded with the site of the internal crack. Long-term prognosis is questionable, but patient is not ready to lose this molar. As you can see, his 4-7 and 4-8 are in a very favorable condition and position. So the plan is, by saving 4-6, he can resume normal function quite quickly, and the MTA will be able to seal the crack better than the gutta-percha and sealer. Hence, this buys the patient some time to seek other consults for backup plans in the event 4-6 eventually fails. Next is the management of a traumatized anterior with an open apex in a 10-year-old boy. Tooth 2-1 suffered a complicated crown fracture and presented like a root stump as the root was not fully erupted. I re-cemented the broken fragment after cleaning up the tooth surface, initiated the root canal through the reattached crown, and completed it in a single visit with MTA obturation and composite post-core. With MTA's excellent biocompatibility, the management of open apices are often predictable. As you can see at 1 month post-op review, the tooth was asymptomatic, patient was comfortable, the soft tissues are healing well, and the attached fragment remains stable. Other examples of cases include the management of endo-perio infections. Both of these cases healed very nicely because the MTA has exceptional seal, antimicrobial, and bioactive. And all of these properties helped in the overall control of the complex relationship. The extruded MTA remained the same and set and does not cause any negative impact on the overall healing. MTA being anti-inflammatory, and this is useful in cases of pain. Its anti-inflammation ability continues up to 30 days after it is activated. Hence, it has lower risk of developing pain after obturation and can potentially continue to neutralize periapical inflammation. So in this tooth 4-5, it had persistent low-grade pain after a few months, for a few months after the obturation, with gutta-percha and resin-based filler. The dentist actually waited for a few months before initiating a retreatment and medicated it with calcium hydroxide for another 2 months. The tooth was still symptomatic, and then the patient was referred to me for MTA obturation. Fortunately, this worked, and patient reported that the pain actually disappeared 3 months after the obturation and went ahead with the crown. So I truly enjoyed using MTA as a root canal filling because I had the ability and could predictably control the obturation using the manual technique, regardless of working length and degrees of canal curvature, for as long as the endophiles can reach them. And all of these are achievable with sufficient training and experience. As mentioned earlier in the presentation, MTA is not without its disadvantages and limitations. However, there are ways to work around them. To mitigate discoloration, we can obturate MTA to below crestal bone level and thoroughly rinse them off the pulp chamber. Alternatively, we can also use newer MTA that does not contain bismuth oxide. So this case was obturated with OrthoMTA 4 years ago, and one had very minimal discoloration at the palatal cervical region, but the labial surface remained unaffected. So overall, the outcome was deemed favorable aesthetically and endodontically. So the next big question is retreatability. MTA admittedly is difficult to retreat. Therefore, we must do our part to ensure that the root canal treatment is adequately performed. We anticipate failure when canals are inadequately cleaned, missed, or blocked. And MTA, being antimicrobial, will not be able to compensate for those. So as of in this upper molar, so there were MB1, MB2, MB3. Should we have missed MB3, there's chance and likelihood that infection will follow. So if necessary, there are a few retreatment approaches that we can employ. Firstly, we can do targeted retreatment, where we can clean and fill the missed canal upon confirming its presence with the CBCT. Or we can actually try retrieving it by using ultrasonics coupled with the manufacturer's retreatment solution if we suspect the primary debridement was not adequately done. Or we can actually manage it by means of apical surgery for those teeth that are accessible. Fortunately, in my past 5 years of using OrthoMTA, I have not needed to re-enter the canals for orthograde retreatment. So, in my conclusion is MTA is versatile and a great alternative material for root canal obturation. MTA is an enabler because it allows us to push the limits of endodontic treatment and stretching the lifespan of a tooth. This comes to an end to my presentation, and I want to thank everyone here for your time and attention. And a great big thank you, Dr. Yu and team, for developing OrthoMTA, because I think this product has done many wonderful things for my patients, and it also has made my work more enjoyable, interesting, and very fulfilling. Thanks again.